to our next your breakout session, Meaningful Roles for Peers, Peer Providers. And I'm Kristin Dempsey. I'm a Senior Associate with the California Institute for Behavioral Health Solutions. I am also the Project Manager for the Greater Bay Area Mental Health and Education Workforce Collaborative. We call it the Collaborative, though, because that is quite a tongue twister. I will say in my role, I've been really fortunate to be able to do a number of projects involving peer providers and peer specialists, and I provide some organization and training and such. And I was providing some training a couple weeks ago, and I asked one of the supervisors, what would you like next? I'm going to prepare something, next week for the peers, and we're kind of looking at items to train on. And she said, well, what you could really do, if you really want to help, you really want to do something important, next step is get some more meaningful jobs for peers. I said, okay, well, I'll get working right on it. So thank you for being here, because I'm very aware that as much as I do believe that's one of the most important things that I or anybody can do, I can't do it alone. So it's really great to have folks in here to be kind of continuing on with this really important conversation about how do we continue to provide more and more consistent, meaningful, wonderful jobs for peers. So thank you for being here. I'm going to introduce our presenters, and we're going to have about 15 minutes or less per presenter. We want to be able to leave time at the end today for us to ask questions. So this is recorded, which is wonderful, so we can always see it afterwards. So at the end, I will be taking questions with the microphone. So you do need to speak into a microphone for questions, just because we are recording. So without any further ado, let me go ahead and introduce our presenters, and then we'll get started. Okay, let me go through my handy-dandy sheets here. All right, so we have Adrian Chilton, MPPA, who's a Director for Intergovernmental Affairs for County Behavioral Health Directors Association. And Adrian joined the mental health movement in 2004, working on California's landmark Proposition 63 MHSA campaign. After Prop 63's remarkable victory, Adrian joined the California Council for Community Mental Health Agencies as the organization's associate director. Since then, Adrian has overseen the implementation of the MHSA and serves as a resource for counties in the implementation of behavioral health services with the County Behavioral Health Directors Association, otherwise known as CBHDA. As a graduate of Knox College, Adrian earned her bachelor's degree in psychology with a minor in Spanish. She completed a master's degree in public policy and administration at California State University, Sacramento, and served as an AmeriCorps Vista volunteer from 2001 to 2002, building affordable housing for underserved communities in California's Central Valley. So we have some construction skills, maybe. That's great. That's awesome. All right. And then we have Lucinda de Rossi. Oops, I think I just lost Lucinda's thing here for 1 second. Excuse me. Lucinda is a public policy coordinator for the California Association of Social Rehabilitation Agencies, CASRA. Many of you probably heard of CASRA. She is also a consultant and a trainer with Inspired at Work. Her work as a consultant has emphasized the inclusion of peer support staff in the behavioral health workforce. As a former executive director of a community-based agency, she provided the leadership and vision necessary to successfully hire and integrate peer support staff into the workplace beginning in the early 1990s. With more than 30 years working in the mental health field, she brings expertise in development and implementation of evidence-based psychosocial rehabilitation services, including supported employment, supported housing, residential treatment, including crisis diversion, and assertive community treatment, FSP. Most recently, her interests lie in incorporating self-management, shared decision-making, and medication optimization into social rehabilitation practice. Okay, so we got some wonderful, skilled people in the room. And next we have Laura Pancake. Laura Pancake has over 25 years of experience working in community-based mental health organizations, providing services to transitional age youth, adults, and older adults with mental health disorders, primarily in the area of employment services, community integration, workforce development, and integrated care. She earned her Master's of Social Work at California State University, Long Beach, and is a licensed clinical social worker. Laura has served progressively as Program Director of Employment Services and Clubhouse Programs, Director of Programs, and is now Vice President of Wellness Recovery Integrated Care Training at Pacific Clinics. Laura currently leads the implementation of integrated care initiatives for Pacific Clinics, including Peer Health Navigation. She also oversees the Pacific Clinics Training Institute, directing the overall design, planning, implementation, and monitoring of internal and external training programs. In addition, she has direct oversight of the Employment Services Program, Benefits Establishment Services, and the Ventura County Transitional Age Wellness and Recovery Center. Laura is also the liaison to University of Southern California for Pacific Clinics, assisting with the development and implementation of joint research projects and serving as co-principal investigator. Okay. And finally, last but not least, we have Karin Lettau, MS, who's the Director of Training at the California Association of Mental Health Peer-Run Organizations, CAMHPRO. She earned a BA from UC San Diego in Chinese Studies and an MS from San Diego State University in Psychiatric Rehabilitation Counseling. An enduring passion for social justice led her transition from a 20-year successful career in sales and management to work in public mental health. Karin is a consumer and family member and has worked as a training, advocacy, and psychiatric rehabilitation professional in community mental health for over 10 years. Ms. Lettau is committed to a recovery, resiliency, and wellness-focused service system. She built stakeholder collaboration throughout California to advance consumer and family member workforce development in public mental health under the former Working Well Together collaborative, and has championed efforts towards state certification of peer family support specialists for over 4 years. Ms. Lettau has experience in curriculum development, training, and facilitation at agency, county, and regional state levels. So we have a panel of very experienced leaders and people who've done a lot of great work around developing peer programs here in California. So I would like to welcome first Adrian to talk a little bit about SB 614 to get us started. Thank you.
Good afternoon. As Kristin mentioned, I'm Adrian Chilton, and I staff legislative affairs for the County Behavioral Health Directors Association, and was asked to talk today about Senate Bill 614. CBHGA was the proud sponsor of this legislation this session, authored by Senator Mark Lettau from San Francisco. And this bill would set up a comprehensive framework for California to administer a peer support certification program. And I really want to just spend a little bit of time just acknowledging our partners here, many of whom are in the room today, because this bill was really built on years of effort, starting with the work of Working Well Together, which consisted of statewide consumer and family member groups and parent partner groups, as well as advocacy organizations such as CASRA and also our important partners, Pacific Clinics. This bill is really is the framework that all of the work that happened at Working Well Together did prior to this effort. So I really want to acknowledge our partners here today. California currently does not have any statewide standards for training for peers, and yet peers are working in almost every county in the state and providing excellent work, and we're also not able to fully capture the federal match for these peer support services. So the purpose of this legislation would be to set up training standards and establish a program that would be administered by the Department of Healthcare Services to set up a certification program. We have examples from about 35 other states that are currently doing this across the nation, and as well as the Veterans Affairs also has a certification program for veterans who are providing these services. This is an evidence-based practice. We have numerous research studies which promote the efficacy of peer support services. And so throughout this legislative session, we have been in our meetings with lawmakers and others have been talking about the value of these services. And I think it's actually has kind of a dual benefit here, which was we were also able to tell the story of the public behavioral health system through these meetings and through meetings that our partners have had with legislative staff. Is really talk about the value of our system of care and the valuable work that peers bring to our system of care. So there, again, this this bill will be a 2-year bill, and so the legislature has recessed for the year this year. So we're working throughout the interim recess here with Department of Healthcare Services on additional amendments that the bill is going to need. Well, as Karen Baylor mentioned this morning, we want to make sure we do this right. And so we've already had one meeting to date with them, and we're planning to schedule meetings throughout the fall so we can get this bill moving next session. It's eligible to be taken up in January of 2016. So if we, CBHGA and our partners really feel that from a policy and a fiscal perspective, this bill makes sense, and we're looking forward to our collaborative partnership with DHCS and moving this bill early next year. I also just wanted to note one thing. In our last policy committee hearing, it was in the Assembly Health Committee, we had over 100 people, peer support workers, come out in support of this legislation. And it was actually, I think, and this is Senator Lettau said this, it was really the first time that he saw the support from the community and the tremendous momentum that our field has for this work. So we had folks speaking different languages, diversity, and so it was quite the showing. So not just the lobbyists who come out in support of the bill, but it's actually the community that came out in support. So we have a lot of support from the mental health field going into next session. So I think as we move into the other panelists and talking about the examples of peer support work, this is really this bill I think is really going to kind of set the stage for the professionalizing the workforce, fully capturing the federal match for these services.
Adrian actually has to be at another place, but is there any questions? I know we're going to take questions at the end, but since you need to leave, yeah, we can take a question or two now in case there's something you're burning to know that you want to make sure you ask before the end. All right. Well, thank you. I'm sure there'll be more, of course, more to stay tuned to for sure. So thank you so much. Thank you for being here. So we'll have Lucinda come on up next. Just as a point of transition here, I have to say when I do trainings, so many things that peers want to know, often, above and beyond anything else, is like what's happening with peer certification. That's always like the top issue everybody has on their mind. So do you want me to go ahead and do you want me to find your PowerPoint for you? Oh, you're fine. Okay. You can see for that.
Good afternoon. I'm Lucinda Rossi, and I am with CASRA. And I have the opportunity and the pleasure to talk about why do we need peers in integrated healthcare. I'm very passionate about this issue, and hopefully you will share my passion when we go through why do we need peers in integrated healthcare? Why do we need integrated care at all? And one of the reasons, obviously, most of us know by now, that we know that if you have a diagnosis of a serious mental illness, your life expectancy is between 20 to 25 years lower than the rest of the population. And not only that, in the last years of your life, you have a poorer quality of life because of comorbidity or comorbid health conditions. We also know that people with this kind of diagnosis also experience the major medical problems that kill most Americans. That is, they have higher rates of cardiovascular disease, diabetes, metabolic syndrome, cancer, and respiratory diseases. And interesting to note, I don't know if you can see the little footer, but all of this information that everybody's now understanding and talking about in the push for integration, this was a study done in 2006. So we've actually known this information since then, and it's a statement about how long it takes to have information until implementation. In this same study, they looked at what were the factors and why did people with serious mental illnesses have such higher rates of these diseases and die so much earlier. And one of the things they found out is provider stigma, is that people have experiences of going to primary health care physicians and feeling stigmatized. And so that creates an access problem. People don't go to get their health care needs met. Obviously, poverty and low socioeconomic status is another structural factor in why people have these problems. Obviously, poverty creates problems in being able to obtain good nutrition. Fruits and vegetables are much more expensive to buy than spaghetti, for example. Again, siloed systems of care are a big factor in people being able to access care for all of their needs, versus oftentimes if you have this kind of diagnosis, you end up at a mental health clinic and really don't get a lot of your other needs met. Polypharmacy is a big indicator, and these are the areas that I'm very passionate about. One of the things that the study clearly showed is that polypharmacy is a huge indicator in your risk factor for early development of disease. Psychotropic medication itself is a huge risk factor, and we know this because weight gain is one of the major side effects of antipsychotic medication, and it is highly implicated in metabolic syndrome, diabetes, and heart disease. So at the individual level, we have other modifiable risk factors. So smoking is a huge risk factor. Whereas 27% of the population smoke, if you have a serious mental illness, that rate goes up to about 70%. So we have a long ways to go in helping people deal with their smoking. Drug and alcohol use, poor nutrition, lack of physical activity, medication side effects, and positive and negative symptoms of the person with the diagnosis also prevents them sometimes from accessing care. So really what the purpose of integrated care, and in particular using peer support specialists who have the same shared lived experience as individuals who need to access care. Oftentimes the peer provider can break down the barriers that have prevented the individual from accessing care, or keep the individual sort of stuck in their position of lack of physical activity or weight gain and smoking. So the hope is obviously that we can achieve the healthcare triple aim, which is to reduce healthcare costs overall, to increase population health, and to improve the patient experience. And I think really that peer support specialists, because you have the lived experience, really can help with the patient experience of the triple aim. Important interventions in behavioral health care obviously are integrated care, but that integrated care also needs to be holistic so that we're looking at the whole person, and we talked a little bit about that this morning. We also need to look at models of shared decision making so that individuals receiving health care or behavioral health care or care for their substance abuse disorder need to really be involved and fully informed so that they can make good shared decisions with the people that they're working with. Medication optimization, and this is where we look at using the least amount of medication possible in order for the individual to have a quality of life, a higher quality of life. So this is a very important concept that I know not a lot of people are talking about when we talk about comorbidity, but it is clear in the research that polypharmacy is a huge risk factor, not only for poor health outcomes, but for sudden death as well. And so I think it's very important that we look at this issue of are we really using the least amount of medications that we can be using to assist people, and looking at alternatives to medications. Do we actually need medications all the time? So it's a challenge to our field, I know, to talk about this issue, but I feel very strongly about it, and so since I'm here, I get to talk about it. Addressing stigma. Stigma is a huge barrier, we know, to everyday life, and it is also similarly a barrier to accessing health care. One of the things that the study showed, for example, is if you were a person with a diagnosis of schizophrenia, you were less likely to get a cardiovascular intervention if you had a cardiovascular event. So in layman's terms, you were less likely to get an angioplasty. That's not layman's terms, but anyway, you were less likely to get angioplasty if you had a diagnosis of schizophrenia than if you did not. So we know that for some reason, people with the major psychiatric diagnoses get less care when they do access care. We need to address the issues of poverty. Poverty is a huge factor in why people die earlier and have a poorer quality of life before they die. And we also then finally, which I'm going to lead into in a moment, is peer support and health navigation, and what role does that play in accessing and utilizing good health care? Not just your physical health care, but your mental health care and your substance abuse care. And as we saw earlier today, your spiritual care, your whole life is important in looking at when you're trying to develop interventions. So CASRA has developed, it was published about a year ago, which is a toolkit on how to integrate peer providers into integrated healthcare organizations. And Laura Pancake is here from Pacific Clinics, and her organization is actually one of the organizations that does a very good job at incorporating health navigators who are peer support specialists into the work environment. So I'm sorry, I'm just stumbling a little bit here because I'm trying to find my next slide that I want to show. And this is just a shameless sort of promotion of the CASRA conference, which is November 4th, and has a very exciting conference lineup, so please go onto our website and check it out. The other thing that you can do is access our toolkit from the home page, and you can download it directly. And what you want to do really is, this toolkit is, I don't know, I think about 180 pages long. It's really meant to be used on the computer so that, for example, it has interactive table of contents, so that if you just want to know what's the research models, what does the research say, you can go directly to that place. And here we have the Bridge, which is the Laura's organization and how they do health navigation. And there are actually 3 research models. One is the Bridge, the other is WHAM, which maybe some of you have heard, out of SAMHSA, and Larry Fricks, and the third one is HARP, the Health and Recovery Peer Program. And let's see, I've lost my page number capacity here. That's not good. So the toolkit also has a number of resources that help people access all kinds of information. For example, you can, what do you need to know about frequently asked questions about supervision? And this is always a big issue. How do we supervise peer support specialists? So you can go to the frequently asked questions section in the toolkit. And because I've lost my numbering system, I have to go back to the, unfortunately, to the toolkit. I think I'll just show you one more thing in the toolkit, and that is looking at job descriptions, which I did have somewhere here. Just one moment while I look for that. Here we go, sample job descriptions. So here we have about 6 different job descriptions. Here's the wellness specialist health coach from SAMHSA. And you can just easily scroll through here and see different job descriptions. So my goal is just to encourage you to download the toolkit. It's free, and it's very user-friendly and very practical, so that if you have a question about supervision, you have a question about a job description, you have a question about what does the research tell us, you can find all of that in the toolkit. And now I would like to, I better not close that. So that wraps up my presentation. Please join us at the CASRA conference November 4th, as well as take a look at the toolkit. Thank you.
Okay, we have Laura next. Oh, sure, I'll just gonna find there we go. All right. And next we have Laura Pancake. Okay.
Might go off on a tangent. Talk about I don't know what. Hi, everybody. Nice to see you. It's been a full day. Thanks for sticking around for this. So I'm Laura Pancake, and I work at Pacific Clinics. And at Pacific Clinics, and I also used to work at Portals, which some of you have probably heard of. We've been employing people with lived experience, Portals, since the beginning. So probably 65 years for that organization, and for probably 20 to 30 years at Pacific Clinics. So when we began to hear the statistics of people dying very young, we knew, and we were seeing it. I mean, we didn't have to hear the statistics, particularly in our ACT, and at the time, our AB 2034, our intensive programs, even in our clubhouses, we were seeing people die at 50 all the time, and we didn't know what they were dying from. I don't know if that's happened to you, but somebody dies and they just don't wake up. They are the program, they go home, 3 days later, they don't wake up, they're dead, oh my gosh, somebody had to find them in their apartment. And so we knew something had to be done. So Dr. John Brecky from USC School of Social Work, I had done research with him for many years, and he approached me with a new project and said, we're thinking about doing this model, what do you think? And as he described it to me, I said, that sounds like a solution, because we're heading into integrated care. This was in 2008-9, but nobody knew what to do. And from this morning, we're still not sure what to do. So peer health navigation, if nothing else, is a fantastic way to do grassroots, ground level integrated care. Wherever your agency is in terms of integration, you can do this at any level. If you're barely communicating with a doctor's office, or you have a physical health clinic on site, it'll fit any model. So I'm gonna click through a lot of my main slides because Lucinda already covered it in terms of why we need to address the physical health care. And we chose to have peers do this intervention because we're very biased. I loved Ron Manderscheid's statement today of peers and family members should be running the system. I'm from old school psychosocial rehab from 1 million years ago, and that's always been where, for me, I'm trying to work myself out of a job and trying to have people who have more experience than me take over. So I like that theme. Anyway, what is health navigation? Has anybody here heard of health navigation before this session? Okay, so I want to make a clarification. I kind of wish we hadn't named it this, because about 6 months after we really got rolling, the federal government announced 50,000 health navigation positions. They were not this health navigation. They were for the ACA, and it was to get people registered and get on the exchange and get your health insurance. So we kept it anyway, but I just wanted to really make that clarification. Now, we certainly did not invent this type of health navigation. It was originally started in HIV and AIDS treatment as well as oncology. And if you're in either of those fields now receiving services, you will still receive the services, if you have pretty good insurance, of a health navigator. I have a staff who was diagnosed last year with breast cancer. She's cancer-free, which is great. She came running up to me. She's a job developer, and she said, I have a health navigator. I have a health navigator. So it was somebody, of course, who had been through cancer and through the treatments and was walking alongside her. So health navigation is a comprehensive healthcare engagement and self-management intervention provided by individuals with lived experience to individuals with severe mental health challenges. So what does that mean? It's comprehensive in terms of we connect people to mental health, primary care, substance abuse, and specialty health care. So we're doing the whole person, we're connecting them to whatever services they may need. It involves engagement because, as Lucinda talked about, people with mental health issues have a long history of having difficulty engaging with the primary health care system. So when we started this project, we ran into some really ugly stories about stigma standing in the way. One of them was a woman who had a lot of shortness of breath, and she had an anxiety disorder. She'd been diagnosed with that. So her psychiatrist, as well as when the staff, a case manager, attempted to get her primary health care, said, of course you have shortness of breath. It's because you have an anxiety disorder, and that's one of the symptoms. So the health navigator became involved, advocated for her to have an ultrasound, and unfortunately, and this sounds very melodramatic, but it's true, she had a tumor about this size on her chest and her lungs. And so the health navigation at that point was to help her access hospice services and not die alone in her apartment, not knowing why, and have some quality of life for the final about 3 months of her life. We've had people who go, they have a rash. This just happened about 6 months ago. The person had a rash, went to primary care. Well, you have schizophrenia, go back to your psychiatrist, things like that. And I know some of you in the room have probably experienced this. So we really try, the biggest goal of health navigation is to get people connected with that primary health care provider. And the last one is self-management. So sometimes people will say, how is health navigation different from case management? Well, we take people to the doctor. We do this all the time. I'm sorry, I'm checking my time. We've done this for years, particularly if they work in older adult programs. The difference is we're teaching them to do it for themselves. Okay, so the idea is you only are engaged in this for about 6 to 9 months, and then you do it for yourself. And it's also in vivo. So we're not sitting in a group talking about you should go to the doctor, and this is how you make a doctor's appointment, and let's talk about how you feel about that. The health navigators, as I'll show you in a little bit, are going with people to the doctor. But they're only going with them to the doctor about twice. And then they're picking it up on their own. So you may ask and think to yourself, which we've been questioned, oh, this must just be for people who are high functioning. I hate that term. Or I try to be nicer and say, do you mean people that are farther along in their recovery? No, this is for everybody. Now, if you're coming fresh out of the hospital, you're in crisis, you need housing, and you're still experiencing a lot of symptoms, you're not going to be in a place where you're going to be able to attend to your healthcare needs right this minute because you have a lot of other things going on, maybe crisis healthcare needs. But it is for everyone. So I just wanted to make that clear. Everyone can learn. Everyone can do this. So we are not a big fan of when people try to single out a certain group of people for it. So the critical elements, we screen and engage people. And when we're screening them, we're seeing, do you need this service? And it's primarily anybody who has any kind of health issues, which for the people that we serve at Pacific Clinics is almost everyone, unfortunately. We do an assessment, and the assessment is very different than a mental health assessment. It asks lots of things in terms of your satisfaction with doctors in the past. Are you engaged with primary health care? What health issues do you have right now? Not diagnosis necessarily, but what are you experiencing? And I'll show you some of the outcomes of that. We set 2 different types of goals, a healthcare goal. So that would be, I need to monitor and take care of my diabetes. And then also a wellness and lifestyle goal, which is I'm going to exercise more, I'm going to eat less. Every time there's a goal, it's almost always I'm going to exercise more, eat less, and smoke less. And those are the 3 biggies, which they brought up this morning. That's it. That's what's contributing to so much of this, along with the psychiatric meds. They help them prepare for the medical appointment, meaning I haven't been to a doctor in 15 years and I'm terrified. Let's talk about that. How are you going to talk to the doctor? What are you going to do? And then they help them navigate the medical appointment. Somebody who needs a lot of support, they may ride the bus with them so they know the bus route. They will sit with them in the waiting room and help them fill out paperwork. The waiting room is a huge source of anxiety for all of us sometimes, but particularly in some of the clinics that our consumers have to go to, it can be very anxiety producing. And then my least favorite part is the exam room because I'm very claustrophobic. So getting stuck in there for an hour and a half, you think you're going to be seen. Some of the people we work with haven't been to the doctor in so long, they don't know that you're going to have to wait that long, or that after 45 minutes, as I do, go out in the hallway and say, hey, I'm still here, when am I going to be seen? And so there's a lot of coaching around coping skills that goes on during that. And then talking about the appointment, did you like that doctor? Was he respectful? Was she nice? How did it go? I didn't like her at all. Okay, then you know what? Let's find a new one. Or do you want to try this person again? And, so we work through them, but the whole idea is to get them a doctor and help them connect with a doctor that they like and trust, just like all of us should be able to have. And then follow-up care. So I heard a statistic, and I don't know the exact numbers, of how many medications are sitting in pharmacies that are never picked up. tons and tons and tons. Picking up your medication from one pharmacy. You're talking about polypharmacy. I also think about polypharmacy, where that's another piece of it. Is of course, having, we have people who go to 4 or 5 different pharmacies, being on many, many different meds, and getting those labs done and following up with that and sharing that information with your mental health provider. That's a big one. Okay, so I'm going to click through. This is some challenge points. You can barely see it, but it's probably the best description of each of those that I just walked through and what the Health Navigator does. Now, they have access to these PowerPoints? Yes, okay. So I highly recommend you look at that one beyond any others. So we have a mantra that we follow. It's for them, with them, by them. So it's basically just modeling, coaching, fading. It's old behavioralist. That was my BA. It was a very behavioral model. But first, the navigator performs the task, and the consumer watches them, and they model it. I'm going to call and make your appointment. I'm going to put it on speaker, listen to how I talk to the receptionist. When I get cut off 3 times, this is what I do, watch me. The next is coaching them. The consumer does it. Navigator coaches them along. And the last piece, which is sometimes the longest piece, is they're fading out and they're self-managing for themselves, but they may need to come back for support. And often what happens is somebody will be diagnosed with something new, unfortunately. They got their diabetes under control. This happened with somebody I work with really closely on a lot of committees. She's one of our consumer leaders in our agency. So she got her diabetes and depression under control, and then she was diagnosed with cancer. So she went back, accessed the services of a health navigator to help her through her cancer treatment. Okay, so why peer health navigation? We already talked about that, and how as Adrian stated, the research shows, or maybe Kristin did, the research shows that when peers are working and people with lived experience at this level are working in a program where they have a really clearly defined job description and know what their role is, just like anybody else, I think that's what happens with our peers a lot, is they're tossed in with very little supervision. When we have those job descriptions, even for ourselves, things go much more smoothly, and when they're working in a multidisciplinary team. So I'm just going to click through that one. So we did a small research project. We just completed one with 150 people. This only had 112. This only had 24. We're seeing really great results from the much larger one. We're trying to have this be evidence-based. You have to have 3 randomized controlled trials for that to happen. Working with USC on that. But anyway, if you look, I'll click through them quickly, and I know I need to end. First, the treated group, the people that received health navigation for 6 months, had an average of 5.9 medical problems. The untreated group had 9.3 health problems. And what this means is coughing, wheezing, stomach pain, pain in their body, nausea, headaches. What we found is, and I'll usually have this slide in here, is that 75% of the people we worked with had 10 or more of these, which is an indicator that the people that we work with have adults and older adults. This is not, I'm going to talk about children in a minute. They're in a lot of pain. And my experience, just from a long, long time of providing services, is that oftentimes people feel like that's part of their mental illness and it's normal to be in that much physical pain. And so a lot of what we do is saying, no, you don't have to be in that much pain. Let's look at this. So we found that the medical problems decreased, thankfully. That was our hope. There was a significant reduction in overall bodily pain, and of course the degree to which pain interfered with their lives. So we saw a big improvement in quality of life. So if you're in pain all the time, what are you doing? You're sitting at home and you're isolating. This was really cool. For the treated group, even though they were getting more physical health treatment by far, their number of physical health medications went down. It was 2, an average of 2. But for the untreated group, mainly because they were going to the emergency room and having medications tossed at them, they were on average of 4.7 physical health medications. Their symptoms, physical health symptoms, worsened. We also saw a decrease in the number of psychiatric medications. We weren't really looking for this, but we found it. And of course it makes sense. If you're starting to feel better physically, you're going to probably need less psychiatric medications. You can also see the cost savings in this, right? Because meds are a big cost. But here's the biggest cost savings, which was really fantastic. We have now found the same type of outcomes in this bigger study. So we asked people before they received health navigation, where do you prefer to go get your physical health care? 33% said the ER and 17% said urgent care. Only 44% said I'd like to go to a doctor. After they received health navigation, the use of the ER and urgent care, unless it was an emergency, their choice of going there dropped to 0. So again, you can see the massive cost savings here. So that's one of the biggest outcomes is people stop using the ER for a cold, the flu. I'm just not feeling well. Instead, they're going to a primary care doctor, which of course is much cheaper, much more effective. Okay, I'll cover this briefly and then stop. One of the big side effects and side benefits of this is we found that the health navigators loved doing this, the people with lived experience. So it's a manualized process. We have a training that's about, I have brochures on your chairs. It's a certification. It's a 4-day classroom training, and then you have coaching sessions, and some of you may have been through it. You go through coaching sessions. As you health navigate someone, then you become certified by, it's a consortium of ourselves and USC. And you become certified as a health navigator. And how many of you have started off in entry-level position, you were thrown in, you had to do it by the seat of your pants, right? That's how I started, probably everybody in the room. And it's really not a great thing. So this provides people with a manual and a way, oh, I do this next, this next, this next. And so their satisfaction in their jobs went up, but they also were attending to their physical health needs a lot more. So how does this fit into peer certification? The way that we see this is, ideally, and this is what's happening a lot of the time, is somebody will become certified by and peer certification by Project Returned or RICA or whoever's doing it, they become certified. And then the next level is health navigation, because it's important to have those solid peer provider skills and peer specialist skills and then move into this. But we also have people that just move in right away and start doing this first. And so we cover motivational interviewing, coping skills, boundaries, and a lot of those things. Cultural issues is a huge piece of the training, so that we're covering kind of all the basics in it as well. Okay, there's a little slide on that, and that's it. Thanks. Okay. Thank you. Oh, I had one more announcement. I'm so sorry. So we were talking about peers and supervising peers, and it's part of the toolkit. On October 9th, you see my PCTIs at the bottom of the brochure. On October 19th, we're doing a free webinar, myself and Dr. Rose Lopez, on supervising people with lived experience. So if you have anybody who's supervising people with lived experience or peers, please have them sign on to that. It's free. And so people say it's very helpful. And that's one of the big issues I find is people are supervising people in a different way when they find out they have a mental illness. I'm not sure why. So we talk about those issues. Okay, thanks. Sorry.
That's terrific. Thank you. That's wonderful. All right. Yeah. So there should be some brochures on your seats. And also, just to let folks know, as far as the handouts, they are actually online at the Policy Forum portal right now. But if you got the YAP app, you've seen that, you can actually get the application, and they'll start to actually load them on there. All right, so Karin's next.
Hello, everybody. My name's Karin Lettau. I'm with the California Association of Mental Health Peer-Run Organizations. And this is a very important topic to me, too. Lucinda and I have worked over the last 5 years on the peer certification, state peer certification, which is a little bit different from a certificate that you receive from an organization that provides training and at your local level, because you can't usually take that certificate to a different county and be recognized. And for the people who are hiring you, if you haven't received a training that is standardized, then they're not sure what type of quality of care that they can expect. So, but I'm just going to talk a little bit about the importance of living the recovery principles in the organization and organizational culture, because that, I believe, is the key to our success in integrating services and providing meaningful and effective roles for peer providers. So, the obvious thing here is simply that we know that contact reduces prejudice and discrimination. And you would think that in the public mental health field that prejudice and discrimination would be lower than in other fields, but in fact it's higher. It's odd, and maybe that's because when folks show up, they're in bad shape when they show up for services, and they haven't been working alongside people who are in recovery and who have learned to recover. So I'm going to talk a little bit about organizational cultures, and because it's so key how we structure our organizations, how we make decisions, what our mission and our vision is for that organization. How is that going to support the people with lived experience providing those services? It's really key. And the nature of your organizational culture can determine whether that peer provider is going to be embraced and supported and be effective. And it's because there's a lot of informal and formal practices that go into an organizational development or an organizational culture. So I'm just going to go over a couple of them here. You can see this is from, personnel. Let's see. Lots of folks, but Kirsch and Gewurz and Spataro are some of the folks that have written a lot about this. Oh, I'm sorry. That's right. Darn it, I promised I would stay here. Okay. Okay, so there's what's found in the organizational culture of differentiation. It's very much like a lot of clinical settings that currently are found in California. There's a hierarchy, and there's valued staff, and those are usually the folks who have the degrees, the credentialing, and then there's the folks who don't have those, and they are often devalued, particularly if you've moved from being a client, perhaps even in the same location where you're now serving as a provider. You still may not feel that equal level. So that's sort of where stereotypical and stereotypes and prejudice and discrimination happen. Then there's the organizational culture of unity, which really throws everybody under the same or a common identity. It kind of suppresses differences. And there's lots of good things about that because it can foster a lot of loyalty. But it also doesn't recognize the value of differences in perspectives and all those different life experiences that can be brought to a team to improve the quality of the services. And then there's the organizational culture of integration. This is pretty egalitarian for the most part, and it really values the different folks on the team, their different perspectives. And in terms of a multicultural environment that we are in California, I think it's really important that we move towards this. And in fact, the organizational culture of trauma-informed care is such an organizational culture. It is an integrational culture. It's totally strength-based service delivery approach. It's grounded in the understanding that we want to ensure that everybody who has experienced some type of trauma. And we know that over 90% of people receiving services, and of course people who have lived experience and are providing services, have experienced trauma. And over 40%, I think, of the general public. So it's grounded in understanding of responsiveness to the impact of trauma, emphasizing safety, the physical, psychological, and emotional safety for both the providers and the survivors. And it involves the person receiving the services. So peer support is a key ingredient of trauma-informed care as per SAMHSA tip. It's really important. So I'm going to try to move on here, and I want to be sure that we have 15 minutes at least to... I'm not going to go through this, but these are this is actually from the New Zealand Lettau folks who came up with this. They have really strong peer support in New Zealand, and these are just some common concerns about peer workers and the responses to that. And then what's really important is using the principles of recovery and resiliency in how we manage the folks and how we direct an organization. So these are the principles, and one of the key things is that staff and the organization believe that people can recover. And you know, I like to point this out because I know that Riverside has that as part of their vision or their mission for the county statement, and I appreciate that. That services are person-driven, always emphasizing self-direction, self-determination, and empowerment. Holistic, obviously. And now I'm going to let you guys do you have the... Oh, you already passed them out. Oh, good. Okay, so if you would just take a look at the first part of what was handed out to you. I hope you have a pen. I know everything's paperless here. If you want to just take a couple minutes and rate your organization for how you believe your organization embodies the recovery principles. And if there's any, we'll just give you a couple minutes to do that. And once you're done with that, if you want to move on to the next one, you can do that. I'm really just going to give you a little bit of silence because I think that sometimes it's hard to just listen to people. Yeah, so it's the first one, so the recovery culture in your organizational rating scale. So so maybe you can, put a mark next to how you feel your organization is at providing hope, that the staff and the organization believes that everyone can recover. Doesn't really think that way. It's really... No, let's just keep them on meds for the rest of their lives. They use a lot of peer support. They, so that would be a high. 5 would be a high. So if you want to, I hope everybody has pencils. Paperless society. I'll lend you mine if you want to do it. Anybody need one? And actually, this particular evaluation comes out of the toolkit. The second one doesn't, but... You just want them to do the front page? Yeah, you can just do the front page. And then if you want to go to the next one, which is rate your workplace for being inclusive. And you may want to just take this home and do it, because I took this from the Burton Blatt Institute at Syracuse University on disability, and I adapted it anyway. So you may want to take a look at how your organization rates, and you can actually do it by rating yourself under yes, it's there, it's in the process of implementing, or it's under consideration. Because these are really important things when you're building an organization, an organizational culture of integration. Okay, I'm just going to take a quick through. I'm going to finish up here and just let you know that in addition to this, and I think it's even on the handout, are some strategies for employers to integrate people with lived experience and the importance, like organizational culture, attitudes towards recovery, how to avoid role conflict and confusion, some of the fears of lack of confidentiality, how that's handled. Most importantly, well, for me, because I can say this here, is lack of training. We can't just throw people in there and just expect them to be able to do it. We have to provide people the training that's necessary for them to be effective. And that's it. Thank you.
Great. Thank you, Karin. All right, so we still have at least about 12 minutes or so for any questions, any feedback anybody would like to provide. Okay, and I have to come with the microphone because we're being recorded, so thank you.
Thank you. Steve Hornberger, you mentioned all of the examples you had were for mental health. Is the same thing true for substance abuse? All of the examples you gave were around mental health issues, not just you, all three of you. So my question is, would it be also relevant for substance use?
Yes, I think so. I mean, it's on, but it's not. What we found is with health navigation in particular, we have to deal with the substance abuse issue first before people are willing to go and get some physical health care or dental care or eye care. So it was originally designed to address physical health care, and then very quickly, because the people we serve, about 85% have a co-occurring disorder. So we had to quickly incorporate that, which I don't know, of course we did. So yes, so with health navigation, absolutely. And sometimes that's the only issue they're dealing with at the time, and not helping them connect to substance use care. So it could be that way.
Yes. Go ahead. You can respond. Go ahead. I have a question, actually. Yes, Jim Gilmer. I wanted to ask you, I like the Health Navigator title, and I do support the peer support and certification. However, coming from the Reducing Disparities Project and ethnic communities and even some faith communities, when you label certain titles, you can sometimes exclude entire populations from navigating to wellness or behavioral health or whatever service you're providing. For example, in some communities, promotora is used, cultural ambassador, cultural broker, some faith communities, lay counselor. I mean, it's all kinds of designations. And we heard the example from Daphne about the African immigrant who might want a healer or something of that designation. So I'm concerned about, we talk about diversity of California, but when we have programs roll out, they're boxing in, these titles. And so what's the flexibility, in incorporating these other dimensions and pathways to healing? Certainly the health navigator is very close to that, community health worker, health navigator. but in some communities, peer is not the methodology that people use to get help.
I'll just address health navigation really quickly. So at Pacific Clinics, we serve an incredibly diverse group of people. So from the get-go, health navigation had to be able to respond to a lot of different cultural needs. And so we have, an example is we have 2 health navigators that work in our Asian Pacific Family Center, and they're of course connecting people to acupuncturists, natural healers. It's the same with our Latino community as well. So they're incorporating that into health navigation. With promotores, what we found is we've trained a lot of promotores in health navigation. They maintain their title because that's what's familiar, but their job does change a little. If you're familiar with promotores, their primary role a lot of times is doing more health education and promotion. And so to work individually with people is a bit of a shift, but they're the perfect people to do it because they're already in the community. So that's been really successful. And so what we've done is encourage people to keep the title of what they're already using and what's comfortable. And that's a quick answer, but I know Karin wants to talk to it.
Yeah, I think that's a great point. And I know that, for example, the SB 614, using the community health workers as partners in gaining access to folks and you know, partnering with where people are. That's the main thing. That's the main thing. And obviously, if that's what they're used to using, community health worker, using that title, that's fine. I think in order to be certified, to be a certified peer or family support specialist, they would have to go through some of the training and ensure that they can pass the test and so forth once that gets to that point. But I think it's critical that we use all the cultural capital, all the cultural networking to reach the unserved, underserved, and inappropriately served. So yes.
But interestingly, SB 614 would not allow promotores to be certified as peer specialists unless they were willing to publicly, acknowledge that they have had a diagnosis or that their family member did. So all promotores, many do, but many also don't. So an agency could have a team of promotores, and according to the bill, only half of them can get certified, correct?
Yes, and the reason is because providing peer support services is quite different in that you use your specific lived experience of having mental health challenges or substance use challenges in providing services to those folks. And that's why it's important, if you have a community health worker who has a diagnosis or is a family member of a person with a diagnosis, that they go through the peer specialist training that can be very extensive. So I hope that might answer your question.
Yeah, it does. It's just that for communities of color and other underserved communities like recent immigrants, it's as important or more important for them that the people speak their language and understand their culture than necessarily have the diagnosis. But anyway, we've already had that discussion, and
Yes,
we don't need to have it. What I'm interested in was the study of the 150 people that are being, what's their racial ethnic background breakdown, and also how many non-English speaking people were involved with that? Thank you.
Good question. So I'm going to take, I don't have this, I do have it, but it's on my phone, but I'm not going to look it up because my phone's all shy. So I'm going to give you a breakdown because I know the program well. I would say it was about 65% Latino, probably 15% African American. No, I'm going to take that back. It's in Santa Fe Springs. Probably about 5% African American. And the remainder, I would say probably another 15% Asian Pacific Islander, and the rest were white. Very small percentage. In terms of language, I'm going to probably make us look bad, but I have a huge issue with it. I don't know if you're aware, so we have a lot of talk about disparities, and people do presentations on the lack of research done with different ethnicities and cultures. Well, I want to tell you why so little is done, because the IRB process, to make it through that IRB process and translating materials and doing the work in a different language is a complete nightmare. Getting through, it's the IRB is the board that you have to get it through to say, yes, you can do research on human subjects. It's a nightmarish process anyway, and if you're doing a research within a county, you have to get the university that you're working with as well as the county, as well as the internal. So you might go through 3 of these. So what I found out is that they weren't doing it. We wanted to do a different research project with our Asian Pacific Family Center, and we couldn't do it because nothing was going to be translated into the multiple languages there, because the IRB process would have taken another year or so. So that's a huge issue, and I know I'm really off topic here, but I have said at this point no more research can be done in our agency until they figure out a way to get the translation done and be able to do it with other in that area. Monolingual, there weren't a ton of monolingual people who were receiving services from us. There are in the area, but though probably 75% of our staff there speak Spanish. So no, they were not monolingual. Nobody who was monolingual received the treatment or was part of the study, which really is not a good thing. So like I said, I'm kind of making us look bad. I'm also giving you an explanation, which is not acceptable. So that's something that I'm battling right now. So best to be honest.
Yes, about peer specialists working with professionals. I would like to see a conference or a group with professionals and peer specialists, people with lived experience, because you don't talk about the discrimination goes on in the organizations, because most peer providers they probably was volunteers first, and they've not respected, and they're used the hardest. And you know, I like, because the peer specialist is on for lived experience, but I think that discrimination between the 2 workers need to be addressed. And this is nothing new. And, you know, I know you have various webinars and stuff, but you don't talk about that. And I think the peer and the colleague need to have a special group where they could come together and respect each other as professionals.
That's a really good point. In the toolkit and in my many years of working on integrating peer support into behavioral health care organizations, is you really have to prepare the workforce. You have to have an open, frank conversation about what are the concerns and the fears of the existing staff when you bring in new staff.
I think they have to admit what's there.
Absolutely.
I mean, if you don't respect nobody, you're not going to go nowhere.
Right, absolutely.
Evading the issue,
Yeah.
it's going to get worse.
So that's what.
Another thing, I'm disappointed, because I know it's a lot of African Americans that was advocating for lived experience peer support, and for it just to be 5%, that is very offensive to me, because, you know, it is.
Well, this was. Yeah.
I was speaking only to the statistics for the health navigation research project we did, which is in a neighborhood that has very few African American people. The original project, which was done just west of downtown LA, about 85% of the people in that project were African American, because that's the population that lives there and we serve. So that's, huh?
Yeah.
Right, so that's different, but she had specifically asked me about the Santa Fe Springs one, so.
Thank you.
And in the toolkit, you can find a number of resources around how to begin preparing your workforce if you are interested in integrating peers. But it is one of those things that if you do not do it, you cannot be successful. And not only that, you cause harm and damage to individuals when they come into the workplace and it's not a welcoming workplace. And I have seen that over 30 years. I've seen it happen over and over again. And it's vitally important that we stop doing that to people and first prepare the workforce for new.
We need to do serious groups around that.
Yeah, absolutely.
And because if you don't admit it, it's not going to go nowhere, because it's definitely it.
Time for one more question, one last question. Okay, here we go.
Hi, my name is Lorenzo, and it's just piggybacking on what you were just talking about. This is more of a statement, right? I'm from San Mateo County, and we actually have. I just left the conference in Oakland, and we visited from San Mateo County to Oakland at a realignment conference, and in a realignment conference, just the agency I'm from, right? Because I'm a client from Service Connect, right? And which is in San Carlos, and we have 3 peer mentors / peer specialists that are African Americans. We have one that's actually 2 that are white, and I'm shooting for the position too. So and we had the social workers there, and we had all the professionals and the vocational advocate for us, and and we all went as a team to a conference as professional and peer specialists and peer mentors. So, I mean, that's in Northern California, but we did it. And we were all there as a collective, you know what I mean? And we were all treated each other with high regard and much respect. And it was like we were all family, And that's just for the record, I mean, it happens, and it's there, and it's right now. And yeah, and I had a question for y'all. So does Wellness Recovery Action Plan, the RAP, Mary Ellen Copeland's curriculum, is that part of the curriculum that is that you guys certify for?
For health navigation, it's not. It's great if people have that foundation. We offer that training separately, but it's not part of the health navigation piece. You can see how well it would fit in, though, you know, in terms of self-care. But for peer certification, yeah.
Okay, cause I'm part of a Voices of Recovery in San Mateo County, and Voices of Recovery, they're also part of our agents. Service Connect agency too, and they do they focus more on the substance, and but they like a lot of our peer support specialists there or peer mentors, they have the RAP too. They have RAP, they have NAMI, they have the other ones. There's some other ones out there, but yeah, that's what I'm. That's why I came. That's why I'm interested in, That's it.
Great, thank you. Just let people know Lorenzo's going to be speaking tomorrow, right? You're going to be speaking here at the conference. So thank you. Yeah, be awesome. So how about another round of applause to our wonderful speakers? Thank you.